Hello, everyone. Welcome to session 3 of AIMS 2022, Bold Ideas Built on Ethical Foundations, the Future of Medical AI. This is Jianfei Zhao, Deputy Editor of NEJM Frontiers in Medicine. So I think the title speaks for itself. In this session, we'd like to talk about some bold ideas about medical AI in the future. So in session 3, our speakers will talk about some bold ideas about the future of medical AI. And so each of them will talk about, within 12 minutes. And in the remaining time, after each talk, you will answer some questions from Gary Wong and from other speakers. And our last speaker will talk about some ethical issues of medical AI. So let me first introduce Dr. Gary Wong, Wang Yongjian, our moderator of this session. So Dr. Wang is professor and honorary consultant at the Department of Pediatrics, Faculty of Medicine, Chinese University of Hong Kong. And he is also associate editor of New England Journal of Medicine. So Dr. Wang's main research interests are treatment, control, and prevention of allergic conditions, including asthma, wheezing disorder, and respiratory infections in children. So Dr. Wang, I'm going to control the slides, but feel free to interrupt me if something is wrong. For you.
Great, thank you, Jianfei. Yeah, we have very exciting sessions. After what we have heard from the previous two sessions, we are ready to look into the future and see what we have right now for authoring us in order to improve the diagnosis and treatment for various medical conditions. And as well, we will explore the potential problems that we may encounter that coming into the future. So the first talk will be delivered by Professor Gao, who is the chief of the Division of Gynecological Oncology in Tongji Hospital, Tongji Medical College. And he's going to speak to us on AI and big data, new strategies, exploration for precision diagnosis and treatment of ovarian cancer. Yes, Professor Gao, please.
So, 大家好，我是华中科技大学附属同济医院。
Hello everybody. My name is Gao Qinglei. I'm from a Tongji Hospital of Tongji Medical College, Huazhong University of Science and Technology. I feel very honored to walk you through some of the work we've been doing around AI and big data in terms of ovarian cancer. First, introduction of ovarian cancer. This is a refractory malignancy for female patients. So the manifestations include the abdominal mass and ascites. The incidence and mortalities of ovarian cancer in China rank #1 in the world, with no more than 40% 5-year OS. Over recent 3 decades, you look at the prevalence, mortalities, and incidence. Actually, it has doubled throughout the past 30 years in this country. There is tremendous pressure in terms of prevention and control of this cancer. Some pinpoints clinically, the 30-70% ratios. As you can see here, 70% of the patients upon presentation are at advanced stage, as the image is showing the diffusive kind of spreads. So there is like a relapse and recurrence, and hence negative impact on the 5-year OS. The 3-70% ratios, we need to carry out those wonderful clinical and basic research in order to overcome the bottleneck with a less than 5 or 30% 5-year OS. Clinically speaking, so as a, let's say, gynecology oncologist, I've been working in this area for over 24 years. I have treated over 10,000 patients of a geo resection and 5,000 times of a geo surgery. This is like MTT big surgeries. Sometimes it may take 8 hours or 9 hours to perform one surgery. However, even with that hard effort, it is difficult for us to turn around the poor prognosis for ovarian cancer patients. We have a Ministry of Education key lab with a floor area of 1,600 square meters. This is a research building of Tongji Hospital in which we're able to carry out the basic benchwork. There are 50 PhD students who are doing on a long-term basis the basic research. But we're not there yet in terms of creating adequate clinical benefits. Are there better alternatives for treatment diagnosis? There is the lack of clinical symptoms upon presentation. Most are advanced stage. For many patients, the 5-year OS is only 30%, but for some early stage patients, the survival could be 90%. The basic problem for ovarian cancer is the early diagnosis. How can we achieve early diagnosis? Screening may play a part, but out of a pity, if you look at the huge cohort overseas with over 300,000 subjects with over 10-year follow-up, usually speaking, it is hard to change the poor prognosis for ovarian cancer through the general population screening. And what about diagnostic modalities? Ultrasound for ovarian cancer or female. It is non-invasive, it is inexpensive, it is convenient to carry out. But the problem includes it is very hard to differentiate, for example, the benign mass from malignancy, and the specificity is not very high. In our clinical practice, we have to look at, for example, the operations, the intraoperative resection of a specimen and a sent for pathology. Then that's how we obtain a diagnosis. But the patients are not willing to undergo those diagnostic surgery. So it's very hard to achieve early diagnosis of this cancer. There is a wonderful trial among BRCA mutation patients. There is dynamic monitoring based on ultrasound B. So those masses may be picked up on an early stage. So there is the window of opportunity theory, according to which there is like a stability of the mass for 4.3 years and a progress rapidly in 0.8 year. So this may offer a good diagnostic window of opportunity. The sonographer's diagnosis of the pelvic mass is different from the AI-based diagnosis. For the latter, there are wonderful applications of AI in other areas already. So we started the efforts, which is in the form of a clinical trial, which is ongoing at 10 sites with 120,000 patients with ovarian mass and over 590,000 ultrasound images. So we've established the early diagnosis model based on deep learning. This is a study design of the trial. We've included 117,000 patients. Upon exclusion, finally, we used 10,000 patients for model building. So there are external validation and internal validation. We've got wonderful validation results. We've enrolled 350 physicians, and a DCNN is pit against these human clinicians. So be it internal validation or a separate external validation, this model turns out to be superior to those sonographers. As we can see, this is internal validation set, the seasoned physicians from top-notch hospitals. The AI diagnostic level is on par with the human beings, but at the lower tiered tertiary centers, the AUC area, say, is way greater than those average lower tier kind of sonographers. Moreover, there is like a human-machine collaboration we've done. So in the routine work that we have on a daily basis, we try to add the AI model. So with AI assistance versus non-assistance, the diagnostic efficacy up by 10 percentage points. What matters more is, according to AI, there are 12 individuals which were identified. So these patients would have been diagnosed early on. So 10 cases are picked up by AI. So 0.9 to 3.7 years before the actual diagnosis by human beings. Then based on this trial, we actually are provoked in terms of our thinking. We look at big data because there is an ocean of data generated in our clinical practice. How are we going to put them to better use going forward? But there are several pinpoints for big data. First, heterogeneous sources of data. There is the lack of a unified standard. Second, there is a lot of non-structural texts. The quality, since the data comes from a real world, is not as good as those of RCT trials, and they are like islands distributed across various hospitals. It's difficult to promote sharing. There is RWD, or real-world data. Now, domestically and internationally, it is well accepted because these are those trials in the real world. So led by academician Professor Ma Ding and me, we have started a new project. For example, at the National Clinical Research Center for OBGYN, and also with the support of a state information center, and also some pharmaceutical companies, for example, AstraZeneca and LinkDoc give us technical support. At the top-notch 30 hospitals, we've initiated this platform. So we spent 3 years collecting in-hospital and outside of the hospital data and information, including inpatient and outpatient service. So we begin with, say, ovarian cancer. Going forward, we're going to look at cervical cancer, for example. We have a call center to perform a follow-up as well, which is going to provide us those needed information of a PFS and OS. Right now, the platform sets out to solve 5 issues, including tech, security, standard, operation, and production output. Basically speaking, it is in a good place to support us. So some of the data, 19 provinces, 22 hospitals, over 20,000 ovarian cancer patients, and over 70,000 cases, and over 100,000 telephone-based follow-up visits. So these data are generated. We perform structural cleaning. There is over 1,500 ovarian cancer-related fields. So structurally speaking, we're able to extract an Excel spreadsheet, which is able to support the clinicians with their basic clinical research. So compared to SEER database and Odyssey, we do have some of our advantages focused on these specialty areas. Then, according to the IDC awarding ceremony, we've got 4 IDC awards because of the digital transformation achievements we've got. So we hope that the AI can better empower our future work. Thank you.
It's a very elegant description of how one can utilize the various data, whether it's clinical, genetic, imaging, to arrive at better diagnosis and treatment. And I just have one question. Very often with these sort of data gathering and subsequent analysis, now surgical treatment, of course, as ovarian cancer, very often, as you mentioned, diagnosed late. Now the surgical management is very difficult from medical treatment. For medical treatment, wherever you are, when you're prescribed with a certain drug. But when you have 2 surgeons or 3 surgeons doing the same operation, very often the results could be a little bit different. So in this sort of model, how do you account for the difference in the surgical outcome of the person-to-person variability in order to make the data set more robust?
Oh, thank you. Thank you for your question. It's a very, very important question. But I mean, this is a model development is for the diagnosis. So it's not for the surgeon. For the surgeon, I think it could be, by person by person. Maybe the different result because it's a very late stage and need MDT collaboration surgeon. It's a very big surgeon, I think. But here is here is a diagnosis. We just use ultrasound image, so it's different from the surgery. Yeah.
That's the subsequent assessment, right?
Yes.
What about and another thing? It's very often when we hear about these analyses, very often we concentrate, particularly with early assessment, like in this case, ultrasound for screening. Very often we'll mention, we pick up so many positive ones or early ones. What about the potential problem of false positive with your, model of AI assessment?
Yes, it's a very, very important question. Yeah. Just like other, I think, diagnostic methods, each method could have the false rate. Yeah. So this, I think, if I could see in the paper, if I realize it in the slide, I think I can. How can I share the slides? Sorry. Yes, the false rate is about negative value. The specificity is about 77% to 67%. It's like that. Yes, still has some yes false rate.
Yes. I'm sure with successive model of these AI algorithm, hopefully one would be able to reduce that as much as possible with successive generation of the algorithm, I presume. Yes. All right. Thank you very much, Professor Gao. And we'll move on to our second talk, who's going to be Dr. Alex Ng, who is the current Vice President of Tencent Healthcare. And he has many hats. He has also been the WHO Digital Health Technical Advisory Group expert. And he was trained in Auckland and also received a master's degree in public health from Harvard. And Dr. Ng, please.
Today, I'm going to share bridging the translation divide, which means that how can we build a better bridge for AI to be adopted in clinical practice? If you're engaged in medical development, I think that you know what it is. Sometimes we have very good scientific discovery, and sometimes it's very difficult to translate it into a pharmaceutical product or medical device to be widely used in the market. But an advantage for us is previously the general public has no idea about medical development, but with the pandemic of COVID-19, now the global population managed to witness that for the pharmaceutical development industry for a completely new virus, how do we adopt the mature technologies like inactivated vaccination and also the mRNA vaccination technology? And also, how can we use some of the existing drugs in a new way? So how do we repurposing the existing therapies? And also, how do we allow it to be revealed and approved and eventually being launched in the market? I think that these are things that or the speed that hasn't been realized before. It's unprecedented. And I think this is the first value. And the second value of this is that now with the product, how can we allow this product to be accessed by each and everyone that needs this product? So for us, this means the entire global population. How can we have access to vaccination, not just the first shot, but also the second shot? And here we also have something that we haven't encountered before. For example, cold chain transportation. How can we make sure we have the first, the second, third, or even fourth jab for the vaccination hesitancy and rejection of vaccination? How do we deal with that? And for such a broad population, the global population, how do we monitor the vaccination? For example, for pharmacovigilance, sometimes we will identify some of the side effects that has very little incidence. So we need a very mature monitoring system, regulation system to make sure that firstly we do no harm. So this is already quite mature, and globally we have similar systems to allow that for each new scientific research project, it will be successfully and safely translated into clinical practice and also guarantee the output at different stage. Then back to the topic of today, potential of AI. I believe that for potential of AI, we are all aware about the great potential of AI. So from education training in medical school to new drug discovery, and also how do we accelerate clinical trial conduct, for example, process management of clinical trials. AI can be conducive for that, and also AI can help with diagnosis and treatment. And for our patients, AI can be used to improve patient adherence, especially for chronic diseases. Adherence is very important. So AI has huge potential in the field of healthcare. So I'd like to share an example about how AI can be used to help solve the problem. In the year 2020, WHO would like to have an initiative to eliminate cervical cancer. So the first approach is vaccination and then screening. The third approach is treatment. I think when we heard about HPV vaccination in China, we were thinking about some other keywords like it's very expensive, very difficult to have access to that. This is because we have a very little vaccination rate of HPV. So in the short term, after we have increased the vaccination rate, we also need to focus on treatment, on screening of cervical cancer. This might not be an issue in big cities, but for places with scarce medical resources, this can be an issue. So we may have lack of personnel, lack of human resources, and medical equipment resources. So what are we attempting right now for cervical cancer screening? After screening for patients who are high risk, firstly, we need to do a ultrasound, a colposcopy to see about the lesion, to understand more about the lesion. And also before biopsy, we need to make sure that we are making biopsy by using by taking the right sample, right measurement. So we need to use the acid staining and also point staining to guide the biopsy process. So now using different processes, we are also trying to integrate AI. So firstly, what we need to screen is firstly where the lesion is, and also at different time point, different time period, the staining features may be different. So how can we capture the features of different mutation, and how do we build a model to determine whether this is normal or not? Because the gold standard here is the pathological report result, whether this is normal or CIN 1, 2, 3. So here we are trying a new model. This is a base fusion model that we have, because if we use the conventional model, then the efficiency is not very satisfactory. So apart from the model that we talked about on the left-hand side, we are looking at the ECGM model performance. We can see it's better than the other models, but most importantly, for this AI to be used in clinical practice, we need to consider how good it is comparing to the performance of different colposcopists. For example, for an intern colposcopist, they only have 73% of accuracy rate. Huawei, for senior ones, it might be 81% of accuracy rate. So here with this validation, AI can really help. We're not saying that AI is better than human, but as a supportive tool, AI can help to improve the clinical diagnosis and screening quality. So I think at the beginning, when we are doing the clinical trials experiment, usually the result is very good. So when we are actually doing the screening in remote areas where there's very scarce medical resources, when we are trying to validate our model in these remote areas, we will face some real issues. So for different devices, we will have different types of devices. For example, we can have optical colposcopy or digital colposcopy, and sometimes you will even have images that are images taken by the mobile phones. So here we have protocol difference, like the angle of the image, and also there are a lot of deviations, and also whether we use iodine or acetic acid to do the staining, all of this will impact our judgment. So we may also face different patient population, and patient population differences may impact the final result of our model. Of course, we have solutions. We can capture a lot of image that fits the scenario, and then we tag the label and then do the training. We can do that. But if we compare then this is like having a new drug. We have a very good RCT. However, in different countries, in different populations, if there's a lot of differences, then does this mean we need to do another new clinical trial? If we have to do that, then it will be impossible for us to do this new drug. Here we have UDI, the supervised algorithm change, so that with more amount of image being captured, we can tag this image, and then with this image, we can retrain the model so that we can increase the accuracy rate of these models. And apart from that, I've been thinking that we already have a very big system to guarantee that in a big city, in a major hospital, that models being trained in different hospitals, different institutions, or this kind of device, this kind of tool, how can we adopt these systems, these models in remote areas? And I remember that when I freshly graduated, even though I did an internship in a big city, but eventually I managed to adopt what I have learned in a remote area in Australia, in a desert area, actually. So my reflection is, if we want AI to be able to achieve what we expect AI to achieve, to improve the efficiency and also to improve the quality of healthcare service, then what we really need is similar to new drug development. We need a comprehensive regulation system. And such a system will be providing systematic support for us to do the development, to conduct clinical trial, to launch a product. But another very important thing is reimbursement, which is something that we are lacking right now. So the paying system is very important. Different from the pharmaceutical products, different from devices. For AI, sometimes it's massive screening, and sometimes it's just specific adoption in clinical setting. And sometimes it's just reference for clinical decision making. So the application is very diversified. So we need a better framework. Even though in different regulation authorities, we have the guiding principles or the guiding regulations, but the scenario is very limited. So building such a regulation system is very important. So now I think that so far we have sometimes very limited solution in certain areas, and AI can help with that, can accelerate the identification of medical solutions. And I think that we can think about how to build such a system together. With that, I have finished my sharing. Thank you very much.
Discussion on this use of AI system in the assessment called poscopy. I just have one question about now, very often when we see these sort of comparisons, very often we pick a group of physicians at various levels of training and then compare their assessment compared to the AI system. I wonder whether it may be a better way to look at it is, with the AI assessment plus the physician assessment, with a combination of the two information in trying to make a diagnosis, I wonder that would be a nice comparison add to your graph, that because hopefully at the end of the day we want to achieve as high as possible, approaching 100%, isn't it, Alex?
Yeah, actually in other clinical trials we have exactly done that, but on certain, if it's just purely a diagnosis, I think it's fine. We do that quite a lot. But I think when it comes to sampling, especially around this one, you need to actually take a sample. It's sometimes very hard to differentiate. Well, before the doctor will say, well, I'll take a sample over there. And then afterwards, right, if the AI gives you something different, right, what do you do? Because this does actually impact the actual clinical practice at a time. And because our gold standard, when we train it, right, it's actually based on pathological confirmation. But when most clinicians, it's based on their optical input, right, based on their eyes and what they see. And so I think naturally, I think for ease of adoption, we tend to do physician plus AI versus physician alone. But there are inherent practitioner biases, right? So So I think we have tried many modalities. I don't think there is actually a industry standard. For example, when you do drugs, you do double-blinded RCT across multiple centers, multiple settings, and everybody knows what to do. I think here in AI, because the way that you use it is actually very, very wide-ranging, right? Whether you do it as a assistant tool, whether you do it as a quote-unquote, I wouldn't say replacement tool, right? But in areas where you actually do not have the resource capacity, right? You do AI to do your first pass. And I think as where I'm advocating is that because the clinical setting where you actually use it versus whether it's actually a diagnosis, whether it's a treatment, whether it's actually a biopsy in our case, right? I think there are just too many variations of this game that I think a much more conscious thought on the framework, right, will actually be quite important.
Well, with the gradual improvement of the AI system, do you envision, in some of the screening procedure, one would be able to replace the physician, assessment, just use the initial AI assessment and to dictate the subsequent management? Do you think that could be the future?
I think this is already on the way. On the things that are more simple, right? For example, if you are detecting your diabetic retinopathy by taking pictures of the fundus when you do last screening, right? I think a very simple computer vision based AI, I think you can do that. But I think what we need to be conscious of that is there are certain ways you can do it. For example, one way will be you dial up the sensitivity of the algorithm so that you over pick up positives. But then what is helpful is that you actually have a physician, right, to do a second pass. So rather than looking over 10,000 images yourself, but you make sure that you overcorrect on sensitivity, right? So you don't actually miss things. But then to prevent from false positive, right? The clinician can actually screen out the potential false positive, right? I think there are different modalities depending on when you do it, but I think it's actually in some ways necessary. But I think now it's really about, I think the science is probably a lot faster than what the system can actually accept and adopt.
That's great.
And I think partly as a result of a requirement of a more robust regulatory framework to guide when and how and where you should be using AI.
Sure. All right. Great. That's great. Thank you again, Alex. And time is moving on, and I will invite our next speaker, who is Katherine Heller. Is a research scientist at Responsible AI organization at Google, and she was in the statistical science department at Duke University. And she obtained her PhD training at UCL in London and a postdoc in Cambridge and MIT. And may I invite Katherine to present her talk on inclusive mobile health technology, especially in the application for the disease, dreadful disease, multiple sclerosis. Katherine.
Hi, I'm Katherine Heller. I'm a research scientist at Google Research. I'm going to talk to you today about inclusive mobile health technology, in particular for our work on multiple sclerosis. Okay, so what is multiple sclerosis? MS is an immune-mediated condition where there's slowing of interneuronal communication. It's a complex interaction between different influences, which can result in the disease taking a different course. And everybody with MS has a unique phenotype and experiences different symptoms. It's a very costly chronic disease, the second most costly chronic disease to manage in the US. Okay, so the problem is that when I talk to the clinicians who I work with, they think of their MS patients often in a way that can be represented by this graph as a complex combination of multiple varying symptoms, a patient who takes medications at different points, has relapses at different points, clinic visits, and annual MRIs. And the clinician, when they meet the patient, has to be able to try to reconstruct this picture, and the more progress they make it in reconstructing the picture, the better they can understand their patients. But the problem is that what the clinician gets is not anything like that picture, right? Typically, a patient comes in and the clinician asks how they've been doing, and the patient will tell them something like the symptoms they've experienced within the last couple of days. So we were interested in ways to deal with how is it that you move from this picture or this amount of information to the more complete picture. So we developed an iPhone app called MS Mosaic, which allowed people to collect data on a continuous basis so that we could get data throughout all times, not just when the patient is in a clinic. And so this data was a combination of self-reported symptoms. It included activity tracker data. It included cell phone tasks like the 9-hole peg test task on an iPhone. And using this data, we found that you could predict certain things that were potentially very important to a patient with chronic disease. So you could predict the onset of a symptom out into the future. And you could also use that to discover subpopulations of people who had that chronic disease. So for example, here on the right, we cluster the data into different groups, and we see popping out a cluster of patients who have primary progressive MS. So it's like a steadily increasing severity of disease, as opposed to relapsing remitting MS, where you have periods of being fine punctuated by periods of experiencing the onset of symptoms. Okay, so what I've presented is a way in which we can use technology in order to get more information on people with chronic diseases, on patients with chronic diseases as they experience the disease throughout the course of their lives. But one of the things that we've thought a lot about and that really weighs on our mind is the idea of how we use this technology to empower patients more. And we started thinking about this in the sense of like, there's a long history of the disempowerment of people who do one-off work or are compensated for one-off work. So here I show piece workers from the 1800s, and there are modern versions of piece workers in today's society as well. And along with these modern versions, you can think of every clinical trial research subject ever. They're compensated for their one-off participation in a clinical trial. And so we really wanted to work to incorporate them more into all aspects of the development of our technology and studies. And we thought about all the different aspects of the study that we were developing and how one might go about incorporating more patient voices. And we were particularly concerned about dropout, which is very common in these app studies, right, where lots of people download the app, but then very few people use the app even a few weeks out. And one of the things we thought about was maybe we're not collecting data in a way in which the patients who are using it are finding compelling. And so we've thought a lot about alternative ways of doing data collection and started trying them out. So here we have images that patients can take to express the current status of their chronic disease. But in the end, what we want is to be able to use mobile technology in order to get more information on everybody with a particular chronic disease so that they can continuously record data about their disease experience, and that data can be used by them, by their clinician, and by other institutions in order to make better predictions about the disease behavior. And so hopefully it can really digitally empower patients more and enhance their quality of care. So some thoughts in conclusion, mobile health technology will be key to the future management of chronic disease. Observational data collection can give us unprecedented insight into health conditions and even aid the design of traditional clinical trials. And I'm a huge proponent of collaboration and the incorporation of patient voices. Thank you.
Great. Thank you, Catherine. Yeah, you couldn't pick a better example. And then this disease, the multiple sclerosis, is very complex. And as you described beautifully, every patient is a little bit different. The combination of symptoms and the severity varies with time. And I was thinking, similar to the control of asthma on a long-term basis, very often we would like to get, the patient's symptoms over a period of time in order to assess how well they've been controlling, similar to MS. And what I find very often is, those patients that I really want data, they do not use it. And usually I find those who input a lot of data into these sort of device and app, of course, very often the younger generation, and usually it's the motivated ones that will tend to provide you a lot more data. I wonder, how we would be able to merge this, how would we be able to encourage those who really want data to input data in this mobile app, and are there any sort of incentivized way of getting our patients to use them? After all, the app and as good as, whoever would like to, input data into the app, isn't it?
Yeah, no, I mean, it's a great question. I think that it's one of the areas that I'm most keen to study, right? Like, what different kinds of ways can we go about collecting data to most incentivize people to actually do it? And I guess a couple of thoughts on that. So one is, yes, definitely younger people use this kind of technology more. So if you look at the people who have downloaded the MS Mosaic app and their ages, it skews about 10 years on average younger than the overall MS population, right? Yeah. That even made the attempt. Yeah. That said, there's also this aspect of, like, the more severely you have the disease, the more likely you are to contribute data. So I know a bunch of people who I've worked with at Duke University have built apps and data collection technology that they've actually not released nationally, but just used with some very severe patients in their clinics, and they get almost 100% adherence to the input of the information, because it's like, if you're in extreme pain every day, right, inputting a couple of pieces of information into an app is by comparison not a lot of overhead. But yes, I think back to, I was actually on a disability panel for people in AI, and this is something that came up just in general, not within the context of multiple sclerosis specifically, but, how is it that you, as somebody who's attending, I was at the largest conference in my field, who's attending this conference with a disability, what is it that you're motivated to see happen? How can we better accommodate you? And almost everybody there was like, we really want to be able to express to the people who are attending this conference what it's like from our perspective to be attending this conference with a disability. And so things like that, things that can jointly help you both submit data, but then also help you do other things like express to people what the experience of your disease is like, is, I think, a very promising avenue going forward.
Yes, yeah. I'm sure with generation of these apps, as well as improvement in our mobile device, it will be more and more interesting. And also you may even have, specific patient phenotype that you can give positive feedback so that they would, get on and use the app.
That's the hope. Yeah,
that's right. Thank you. Yeah, very good. All right, and we'll move on to our next talk. Thank you, Catherine. Thank you again. Our next talk is going to be given by Professor Liang Wenhua, who is a professor of thoracic oncology and assistant director of Oncological Center in the Sun Yat-sen University. And Professor Liang is going to speak to us on AI and precision medicine in lung cancer. Yes, Professor Liang, please.
Okay, thank you, Professor Wong. I would like to share the screen, please. Okay, that's fine. Okay, thank you, the New England Journal of Medicine and Professor Wong Good afternoon, ladies and gentlemen. This is Wenhua from Professor Jianxin He, Nanshan Zhong's team. Our hospital serves as the National Center for Respiratory Medicine of China. We are honored to be invited to share some of our works using the AI to improve the precise management of lung cancer. First of all, I think there are two modes for clinical application of AI techniques. One tries to mimic what human beings do, then to replace them in order to save human resources. Another is beyond what human beings can do, where there is not any established experience. For our group, we focus on some interesting niches that only AI can make it happen. Here, we would like to share 3 pieces of work: radiomic AI for predicting the molecular status in very early stage lung cancer, a deep learning-based biomarker integration for diagnosing lung nodules, as well as the pathological AI for predicting the gene profiling. The targeted therapy, EGFR TKI, is mainly used for late-stage or invasive lung cancer. We previously proved that they can treat small pre-invasive lung cancer for the first time. However, the response rate is 34%, only half of the expected number. The major reason is that only lesions harboring EGFR mutation are sensitive to these drugs. We have to know the EGFR mutation status before we use the drug. Traditional tissue or liquid biopsy is not available for these tiny and diffuse lesions. Therefore, imaging-based diagnosis represents the only option. There are previous studies show that some typical radiomic features can help to diagnose the molecular status. However, GGO lesions are at a very early baby stage of the lung cancer, have not any such features. Just like we can roughly tell an adult is a good guy or not, but it's hard to differentiate a baby. So it is interesting to know whether AI can identify some distinguishing features out of our knowledge. Surprisingly, we were able to extract 252 different radiomic textures between EGFR mutated and wild-type lesions. By using gradient boosting decision tree, we built a model with an AUC around 0.8. When we applied this model to the clinical cohort, we could see the response rate of the lesion predicted to have EGFR mutation is doubled to the blinded use, suggesting that this model accurately and effectively enriched EGFR mutation. The second work is about the differential diagnosis of the increasing detected lung nodules. Previously, we have established a blood-based DNA methylation model, PAMO-6, to tackle this problem and validated by a multi-center study of 1,200 patients. To further improve its diagnosed performance, we try to additionally integrate the clinical features and CT features to develop a combined model, PAMO-6, for benign and malignant nodules classification. Theoretically, imaging is more sensitive among non-shedding lesions, while ctDNA biomarkers are more specific. Therefore, imaging and ctDNA are complementary. We used machine learning rather than traditional linear models to synergize the larger scale multi-mode features to build a PAMO-6 Plus model. PAMO-6 Plus showed an improved performance over PAMO-6 and imaging model alone, with 6% improved AUC and with 5 to 6% improved sensitivity. Sensitivity of PAMO-6 Plus was more than 98% across different nodule sizes, which was superior to PAMO-6 alone. In clinical implementation of PAMO-6 Plus model, by reclassifying the physician undetermined nodules, PAMO-6 Plus would have reduced 89% of unnecessary surgeries and 73% of delayed treatments. The third attempt is to use pathological slice to profile gene mutation, which is essential for selecting right drugs for lung cancer. The routine gene test is time-consuming, which is not friendly to those in urgent need for treatment, and it is relatively expensive to undeveloped area. A gene profiling AI based on scanning tissue section is of great value. Thus, we collected approximately 5,000 matched scans from cases profiling by NGS from multi-center in China and developed an algorithm named DTMU to help diagnosing the common mutations such as TP53, EGFR, and KRAS. DTMU is a multi-instance learning method for gigapixel pathological image analysis. It uses the deformable architecture to effectively integrate information of all subregions of each WSI to perform the prediction, which can adaptively adjust the contribution of each subregion and consider the position information of subregions during the prediction. The AUC across different genes were around 0.76 in surgery samples and 0.69 in punctured biopsy small samples, which were validated by external cohorts. Our methods outperformed the established deep path method in China cohort, mainly attributing to the upgraded segmentation resolution and algorithm. Our method also outperformed deep path method in TCGA cohorts on which the deep path established, suggesting the generalization of our model. In addition, we illustrated the area with diagnostic value to interpret the model. And to facilitate future clinical use and ensure the reproducibility, we also developed the automatic labeling by learning the manual label and showed similar results. That's all for our brief sharing, and we would like to thank our collaborators from Tencent AI Lab and Encodix and Burnrock. Thank you for listening.
Thank you, Professor Liang. And I've been asking a lot of the questions, and all the speakers actually would be, if you have any questions or comments on the presentation, please do. And I'll just start with the very first one about, lung cancer. Of course, there has been dramatic explosion of the understanding and the various genetics and the complexity. There used to be just a few types of cancer and that's it, and all patients are treated the same way. But there are not many examples, of cancer that are very benefit from the understanding of the molecular genetics and the fine tuning of the treatment, as well as the prognosis as a result. And now, how do you see? Now, very often I find these methodology of classification, actually, it's much more advanced than the treatment available. And probably it's because of, just like a few talks earlier, developing a drug and testing a drug, it's much more cumbersome. And I wonder whether there are ways, from the AI aspect, in addition, what we had discussed before, to speed up and improve the therapeutic options for patients, particularly in this field of lung cancer.
Yeah, that's a great question. And I think the AI can help to identify new drugs or the new application of the old drugs to try to fit the structure of the protein we target and the molecular structure of the small agents or some big molecules to help us to increase the efficiency of the screening process. And so then we could narrow down the candidates we would like to develop the drugs.
Yes. Yeah. And any other comments or questions from other speakers? Alex, what do you think? I guess Tencent's been involved in the assessment of this. What's your comment on this? Where are we heading?
Well, I think rather than as Christian is more of a comment, right? I think we are getting into an area where different from drugs, where it can be developed and tested very independently, right? Being used in a broad population. A lot of the AI the potential of AI is really about augmenting the physician experience when it comes to education or practice, right? And I think for this, most doctors will know how to prescribe a drug, right? And know how to interpret a table, right? But how would any AI augment their practices and the behavior? I think that is actually the key. And to me, I think this is where it's heading is, in my experience is that clinicians right now, they finally know what AI is, but I don't think they realize, they don't have a deep enough understanding on the potential, not just the potential, I think there's the potential, right? But also the guardrails around the pros and cons of different AI and how do you actually augment it. So I think this is a different MDT we're talking about. If you think another allied health professional can actually help you in your practice, I think AI should be treated as one as well.
All right. Yes. Very, very well said. All right. And thank you. Thank you, Alex. We'll move on to our next talk. Will be delivered by Professor Han. Professor Han is the medical AI specialist and is also an expert, well-known expert in the field of bioinformatics. And he's also the senior researcher at the Guangdong, Hong Kong, Macau, Greater Bay Area Precision Medical Research Institute. And his presentation is on RWD-driven smart pediatric CDSS system. Yes, Professor Han, please.
各位线上的老师朋友，大家好。
Dear participants, hello everyone. I am Lianyi. Thank you very much, Gary Wong, and also Professor Zhao for your invitation. And today I'm going to share with you about the RWD-driven smart pediatric CDSS system. So the background of this project is from data perspective. In recent years, the medical information is becoming more and more complex. Disease diagnosis, treatment, and biomarker are increasing exponentially. Clinical decision is becoming more important and more complex. Also, in the decision-making process, we do need a lot of data to make an informed decision. So in medical field, in algorithm, AI, CV, NLP, NLU has already demonstrated great potential in imaging-based diagnosis, especially in radiology, dermatology, and ophthalmology. But for EMR data analysis and application, we still have a lot of challenge, including, for example, large amount of data and also the deviations and also systemic bias. So with the improvement of the technologies, we hope that we can redefine medical issues by using AI. And also we want AI to be a very useful potential tool to mine the EMR and RWD data so that it will be able to mimic or augment the human doctor decision-making process. So today I'm not going to elaborate about the feasibility and effectiveness of AI use. And here I'd like to firstly talk about the background of this project. So it's a collaboration between National Pediatric Center and also the Hong Kong, Guangdong, Macau, Greater Bay Area. So for the unmet medical need here, this is the diagnostic issue in the pediatric outpatient clinic. So based on the gender, age, and chief complaint, as well as the physical examination, current disease history, according to this triage information, how can we recommend a possible disease diagnosis? And also we want to provide decision-making support to avoid and mitigate the misdiagnosis and also improve the comprehensive quality control. And here for data source, I would like to demonstrate here is about the source of the data. It's from the pediatric center and also Fudan affiliated pediatric hospital, our big data platform from our HIS outpatient EMR, and the data volume is 7.33 million EMR ranging from 2017 to 2020. And the content of the data is gender, age, chief complaint, department, etc.
So we can look at those cases and a feature extraction, as well as those synthesis detection so on and so forth. So this kind of a training sample we have, then we give it to feed-forward neural network. So end-to-end, we set up a clinical decision-making support model. Through testing on separate data sets, then we come up with those preliminary results. The independent data set is completely separated from those training data set in terms of the time. So we've obtained over 100,000 cases. And with pre-treatment, we come up with 90,000 testable cases covering over 50 departments. Then we carry out preliminary assessment from a top 1, top 2, all the way through top 5, and come up with those assessment results. If you look at the AI diagnosis, and the matching ratio can be as high as 93%. With the 35 categories we classify into department-wise, and 92% of the departments have a matching ratio of above 80%. And the results of the medical departments are better than those with the surgery. As we know that after pre-treatment, we've included 91,000 pieces of data. Then we look at AI diagnosis. There is good kind of a hint that we have obtained from the AI system. So there is 20 specialty area with a number of testing cases of over 1,000. The top 5 diagnostic matching ratio of greater than 80%. And for ophthalmology, actually, this has the best diagnostic outcome. But there is the huge number of data at dermatology and a medical department. There's different disease types covered. It is in need of more clinical data going forward. That in terms of orthopedics and rehab, the matching ratio is under 90%. And based on physician assessment, we need to look at even more data points of the lab testing results in order to provide better assisted diagnostics. This is a trajectory. We released the version 1.0 back in 2020 and that launched at the EM at the Children's Hospital affiliate to Fudan University. By 2021, the release 2.0 was launched in different places, including in Hainan. In 2022, the standardized version launched at multiple places, including the headquarters and the Hainan Children's Hospital, Anhui Children's Hospital, Jiangsu, Yunnan. So this is a project intro. Thank you for your kind attention. Thanks.
Exciting data and looking at how the AI system and analysis data would help in the diagnostic process in pediatric disease. And I wonder, I've been in eye hospital nowadays, a lot of hospital records are, gradually being, computerized and, just punch in a few keywords, you can retrieve a lot of information. My experience has been, because the data set is as good as what you put in. I find, very often, it's just like when you try to take a history, a very young, inexperienced clinician versus a more experienced clinician. They spend, 5-10 minutes with the same patient. The experienced clinician usually would be able to quickly get the most essential information and put it in the model that the essential information will arrive at the correct diagnosis. While the inexperienced person, who are unable to obtain the most critical information from the patient. And of course, when you have not acquired important information, you feed in the model, the diagnosis at the end will be wrong. I wonder, how we may be able to reconcile this, what I call the human factors, and then the computer AI analysis of information obtained. So I would like to hear your advice, how would be, the AI system is as good as what information you feed in. I wonder, for our future analysis and improvement of the AI system in terms of diagnosis, how we would be able to improve, obtaining information that we feed into the system. Dr. Leo, would be nice to hear your advice.
Thanks, Dr. Gary, Dr. Wong for the excellent question. And I think that's a very good idea. And I'm willing to add one more because the use of AI in the CDSS is not new, and it's also very challenging in some of the areas. And the AI, the human expertise, especially from the experienced doctor, they do play a very significant role in this. It's because I don't think AI can better perform with those best group of doctors. And the human intelligence, in many cases, play a role that are creative. They are trying to solve the 100% case that AI or other doctor cannot solve. And having those intelligence there, the human intelligence there, plus AI, where it can cover the 95% of the cases, that's easy to diagnosis. And as well as combine them together, hopefully can provide a better system in the clinical setting that we, for each patient, we have more confidence and we have more coverage, and we lean to provide much better clinical healthcare for them. Mm-hmm. In many cases, the rare disease diagnostics, yes, as well. In many cases, the rare disease diagnostics, it's definitely beyond the 95%, I think.
Mm-hmm. Yeah, I find it very interesting. When we look at the accuracy, for example, diagnosis, the eye disease, the skin outperform the other ones, and it appears it's like if you have now in terms of the number of diagnoses, in terms of skin condition, very often is you look at the lesion versus a complex medical condition that requires the clinician to take a long history in order to assess what's going on. And that's probably and then I can think of also another discipline, which is psychiatry, because psychiatry almost purely rely on the type of questions you ask, the type of information that the patient is able to give you. And same thing, if you have the same type of patient, two physicians, one experienced one inexperienced one, you ask the same question, actually the answer from that patient will be slightly different, because experienced clinician use when you look at the patient, you look at the facial expression, how they answer your questions, and then you kind of get an idea whether the patient is able to understand your question and express the symptoms to you. And then, well, I'm sure, as the AI system improve, we'll be able to get, this human factor and the technological factor and put them together in order to improve our diagnostic skills. Yeah, very interesting. Yeah, thank you. Thank you, Dr. Leo.
Thank you.
Yeah, thank you. So with that, I will pass on to Charlotte Haug, who is the medical correspondent for the New England Journal of Medicine, to give us the concluding remarks. Charlotte, please.
Thank you, Gary, and thank you to all the speakers for this very interesting and important session. As you just said, Gary, artificial intelligence opens up such a great variety of potential for the diagnosis and treatment of patients, including involving the patients themselves in their own management of their especially their chronic diseases, which is, after all, the most important part of diseases, this burden of disease. But as this session has clearly shown, there are also limitations, and as the field matures, the limitations becomes more visible. It could be that we will not be able to replace the human factor with technology. Mm-hmm. We will instead have to find ways to combine those two. And then, of course, this last presentation, a very nice presentation, reminding us that all medical practice is, deeply ethical and personal practice, and we always have to think about the ethical issues. But the use of artificial intelligence and big data, very personal data, I might add, introduces a whole new set of ethical considerations that are also very cultural, and that's why it's very nice to have an international discussion about these topics. And we're, as I think everybody is in agreement, we are in the beginning of this big conversation, not anywhere near the end. So it will be continued. So again, thank you everyone for sharing your ideas and your insights. Now, Eric Rubin, the editor-in-chief of New England Journal of Medicine, would like to close the meeting with a few words.
I'd like to end today by going back to where we started. I think that AI has a huge potential to be a game changer in the way that we approach medicine and medical research. And I think we learned something of that today. So I'd very much like to thank all of our speakers, our panelists, our discussion leaders, and particularly offer thanks to the organizers, especially John Fei, Ping, and Charlotte. Thanks again, everybody.
Thank you. Let's close off the program today. And thank you so much for our speakers.
Yes, thank you very much for all the speakers. Wonderful presentation. I learned a lot. Yes.
Yeah, that was very nice. Very nice, all of you. So.
Yes, thank you. So I'm sure we will sometime in the future reconvene again, maybe hopefully in a physical place, face to face.
Yes, let's do that. Let's meet.
Yes. All right. Okay. Yeah. Bye-bye.
Okay.